So, good morning, everybody. Did everybody get your tea or coffee or whatever? I got my tea over here. So we could talk and relax and talk about some tips in the surgeries.
Good morning, everybody.
Sorry.
Did everybody get your tea or coffee or whatever?
Okay, this is live on YouTube. Okay, we have a delay in YouTube for about, I think, 15-10 seconds, Aishwarya. Interesting.
Yes, sir.
And, okay, it's right here. I usually open both browsers because Zoom is usually in the Safari. But if I open Safari and I open the WhatsApp inside the same browser as well in the computer, so things get a little heavy, so the internet doesn't flow well. So I usually open Safari. I usually open Google Chrome for the WhatsApp in case I need to communicate. It's better than typing here in the cell phone.
Yes, sir. You can actually get WhatsApp for web. You don't have to open it in a browser, sir.
Yeah, no, it's easier to the WhatsApp inside the telephone, but sometimes it's good to see. It's better.
Yeah.
It makes our life easier, I think. So, well, why did I choose the subject of internal limiting membrane peel? Because actually we do internal limiting membrane peel in some special surgeries. We can tell macular holes, epiretinal membranes, usually vitreomacular traction, but for solely epiretinal membrane surgeries, we do not always have to do the peel of the ILM. But the experience proved that sometimes we have to deal with the ILM for epiretinal membrane issues, and also diabetic patients when we have the very adherent internal limiting membrane, and also contributing for persistent macular edema or other changes. So we got to think of doing epiretinal membrane peel and internal limiting membrane peel all together in some cases. Good morning, sir. He's on surgery now? Yeah, good. So I will share with you my screen over here, and I got this video from the ITU that I published some time ago. Actually, last year it was published on ILM folding technique for macular holes. So let me share the screen first. Can you see the screen? I'll just pause it for a while. Okay, can you see the screen? Large macular hole ILM folding technique. It is there. So let me enlarge it a little bit. So this is a quite interesting video showing whether you should deal with the ILM or not to deal or not to do anything for the ILM. But in the past, I remember back in 1996, 1997, when I started my fellow in 1997 in Canada, we did macular hole surgeries, but we did macular hole surgeries the usual way. I was in the OR in Canada with Dr. Deveni. He used to do the ocular vitrectomy, and we did as fellows as well. And we did not build the ILM as of yet. But then, with time, we started building the ILM for macular holes, and it was a different thing. We still were doing 20 gauge. So 20 gauge is not was not as efficient as 23, 25, and 27 gauge as we do today. And so we were doing 20 gauge, and surgeries lasted a little longer. But there was some concern on closing the macular hole. So the blood was centrifugated and injected over the hole, and that increased the likelihood of getting the hole closed. So that was the surgery we did. And interestingly, at that time, we used the wide-angle systems, but not very often. We used the wide-angle systems once in a while. And I brought this news from my previous retinal fellow that I did here in Brazil. And I was telling Dr. Deveni and the other guys there, well, we should do more wide angle because we see the whole thing. It's better for us to do the vitrectomy. But still, the macular work, we applied the macular lens to see it closer. Okay, so let me start the video.
These are the pre-op OCTs and FA. The macular hole measures 844 microns as measured by OCT. It is a large stage 4. The hyaloid is already detached. That's a regular vitrectomy, not inverted, with an air fluid exchange. We now use a wide-angle lens. That's inverted vitrectomy. We are using a macular lens with a great visualization. After brilliant blue, you actually have a very good view from the ILM. We open up a tear in the ILM, a vertical one. We start the PO in a rexis-like movement, counterclockwise, lifting the internal limiting membrane and relieving all tractions around the macular hole. We complete the PO, leaving a great part of the ILM intact, as you see.
It's interesting that you see that how did I start the PO? And this is the detail. I grabbed a very localized part of the ILM superior, so far from the foveal area. So that's the way you should avoid the foveal area. And then I created this tear. And from this tear, interestingly, I moved the ILM to the opposite side. As you see here, it's very interesting where you get the ILM creating that tear. The first thing is to create the tear. It's not always easy to create the tear, but you see here, you go not deep into the retina, but you get the ILM, you go like a pinch movement. You do like a pinch movement at the macular area, but just below the arcade, as you see, you have the brilliant blue staining the ILM very well. So you have a pretty good view from the retina here. And so,
view from the ILM.
See, you created the tear there, a small tear, just a tiny one, and then just spread it, go towards the inferior part.
We open up a tear in the ILM, a vertical one. We start the peel
So it's easy
in a
to start
rexis.
a vertical peel. A vertical peel is not difficult to do. So you created that small tear. You see the vessel over here. You got to be very careful not to go deep and perforate deeper and cause any bleeding. But when I got this small pinch over here and went downwards, I opened this coma-like tear. So what to do now? Should I keep going here and grabbing here and go around? No, you don't need that. So since you open the door, you just have to get, like a leaf flat here and follow the other way around. Take a look.
Like movement, counterclockwise, lifting the internal limiting membrane and relieving all tractions around the macular hole.
So this is interesting because I grabbed the edge of the ILM that I just opened and went towards the optic nerve. So it was already open. So I just have to follow. In case I miss this here and I don't have this part here anymore, what should I do? I should re-grab here again. And I will start from where I lost the internal limiting membrane. But this internal limiting membrane came out very easily. Very good way to peel the membrane. Take a look here.
Complete the peel, leaving a great part of the ILM intact, as you see. It's very important to get the most of the membrane.
So you get the most, to get the bulk of the membrane and keep on peeling. The thing is that if you have this shape, take a look at this shape of the ILM, you have this round and tubular shape of the peel. You should leave it where you can see it. You should not just raise the flow or increase the bottle height, meaning that increasing the intraocular pressure, and then it's going to escape elsewhere. So how to keep these small pieces of ILM there, so where you can see it, and so that you're going to use this for some purpose. Do you have any idea, Aishwara? Rodrigo, do you have an idea what should we do with this?
So what I have seen is generally that is used to plug the macular hole to like ensure that there's better closure.
Yes, that's what I want to do. I want to plug the macular hole, but this is usually people get the shape of the ILM like a flattened shape. Could be easier, but maybe could be worse because the ILM could fly around the vitreous cavity and then you won't see it again. And what to do? I will tell you what I did in this case. So I kept on doing the ILM build.
We now use the closed tip of the ILM.
Now take a look. So I completed the peel. It's round and beautiful. And if you see my tip, my ILM forceps tip, it's round, very, very thin, round, but it's not sharp to cause any harm. So I got the ILM. I avoided the ILM from floating around the vitreous cavity. I was just holding it on the retina, but without pressing much. You gotta be sensible. You need sensitivity to get the membrane and not forcefully put it over the retina and create another tear, a deeper one. So you gotta be very careful this time and do things very slow. I just get the ILM below the tip of this forceps, and I keep walking towards the macular hole. But how to walk it without damaging the retina? You gotta have the sensitivity in your hands attached, linked to the forceps and also to the ILM. You gotta feel it. It's not easy to feel the whole thing but you gotta have your hands feeling the whole thing. Even the small, very small, different thing on the tip of your forceps, you might feel. You gotta feel it, otherwise you won't be able to do to make this movement.
To actually move the ILM into the hole.
So I'm moving the ILM into the hole. You see the tubular fashion of the ILM here. That's the way it was. It remained after I peeled it off, but it could be open, so you could do the same movement very carefully. So because this was a large macular hole, a large one and long-standing, we decided to do this technique. So I put the ILM on the hole, and with the tip, be very careful not to damage the RPE, which is below. I just inserted the ILM
in a very slow and gentle fashion.
Very slow and gentle fashion. See?
We go downstream from nasal to temporal towards the hole.
So you see, you still have that piece over there, but I'm gonna tell you the hole is already filled, so you don't need to be to keep putting things inside the hole. It's a stuffing technique, so it's a way to deal with the ILM. So I will do that one with.
Since the hole is a large one, the tip will fit in without a problem. You see now the membrane rolled over itself in a tubular fashion that makes it easy.
So as you see here, the ILM is already there, and so we don't need to keep doing anything else by this time, unless the ILM escapes out. So you've got to be very gentle and avoid too much of a flow in the vitreous cavity. So if your pressure is 40 or 30 or 35, it's okay. You should not raise it more, and actually you should keep it around 30. If you have the constellation systems, you have the pressure controlled to 30, 35 is okay. And you have the Stellaris, for example, from Barcelona. You gotta be putting the intraocular pressure a little low, otherwise the flow from the infusion line is gonna displace the internal limiting membrane. So you should understand how to do that without damaging the RPE in very slow fashion.
We proceed now another.
As you see here, the hole, how large is the hole? You see how large is the hole? And we got these ILMs in this tubular fashion. So using the tip of the forceps, the round tip of the forceps, I put it inside. There are some other, it depends on what you like to do and what is good for you and what does not damage the retina. Of course, this tip is perfect for that, but some have the, even here in iTube, we have some videos showing the, what they call the massaging tip or other different tips. You gotta be using whatever you think it's good and the way it wouldn't damage your retina anyway.
AFX, air fluid exchange, postoperative period.
Now I'll do an AFX, and then you're gonna see the postoperative period, the whole starting, closing.
Number 7 shows very clear media and a clear lens and a closing hole with the edges approaching. Thanks.
So this is a very interesting way.
This is inverted vitrectomy, ILM folding technique for large macular holes.
This is coming from elsewhere, I don't know where. Okay, we finished. Let me just stop it for a while. So if we are going to deal with the ILM for the purpose of doing the macular hole surgery, we gotta know how to peel it. Of course, the best way to peel it is doing the a good brilliant blue or ICG, so it makes it easier to get the ILM. We just see here another surgery involving the So this is another one. This is one I just showed you, the ILM folding technique. ILM folding technique is a very fancy one, but we have membranes involving diabetic patients. We have membranes very adherent. We have double peel like I have here. This is a double peel where we first peeled the apparatus membrane, and then when we took care of the internal limiting membrane. So we have interstitial syndrome, this surgery here. We got the ILM with the cutter. This is very interesting. And this is interesting to see. Some ILMs are very taut, meaning that you don't grab them very easily. And this is very interesting because if you have a very taut apparatus membrane, how can you remove it without damaging the retina? This is another one, was a double peel for diabetic patients, and some diabetic patients, they had laser, they have their intrinsic retinal changes, so it might not be easy to get the internal limiting membrane here, so you gotta be very careful. And in this case that I'm gonna show you, still in ITU, and then we proceed to Oshima's video. We have here
taut retinal membrane ILM
membrane. So
that's a case designed for taut retinal membranes.
How to deal with taut
You can
retinal
notice
membrane?
by the FA and OCTs that the retinal membrane is very...
Take a look here. It's always interesting to have the autofluorescent because you see how deep is the membrane standing there. If you just take a look from the indirect towards the retina, you might see the membrane, but if you don't have an OCT and the whole angel, you might not see how the membrane is deep there and causing bad visual acuity. But this was not so bad visual acuity. This was 2040 to 2050. So I decided to operate on this patient because otherwise the membrane will be very deeply rooted and the outcome will be even worse. So
coherent and deeply rooted on autofluorescence. The OCT from top to bottom discloses the irregularity of...
So as you see here, the OCT shows how irregular is the membrane. You don't see the foveal shape very straight. And so you see here on the left, in the OCT image, you see here the retinal folds as well.
Retinal membrane on the macular surface. Start now the inverted 23 gauge vitrectomy using the wide-angle contact lens.
So we already
with the core
here.
and peripheral vitrectomy and use brilliant blue.
We already here did the fluid exchange, and you got a very good view from the macular area here. Everything is bluish, and you see the internal limiting membrane there. So how can I go over the internal limiting membrane without damaging retina? So still, you got to be very, very careful.
We display color.
As you see here,
On the right point to the appropriate PO.
my default speaker changed. Let me just a moment here. Let me switch it back again for the other one.
Removing preoperative CT helps to see the macular adhesions.
Here, I'm grabbing the internal limiting membrane again with the tip of the. It's saying that my connection is a little unstable. That's my. You see? Can you see me? Okay, it's okay here and in the. I will get the connection from the cell phone as well, just in case. Can you hear me? Can you hear me, Aishwara? It's okay.
Is where the membrane is more adherent.
Yes, it's better now. Yeah.
We start the PO.
You see, I'm getting the internal limiting membrane the same way, but it did not go just the way I wanted to go. So it's like I did the internal limiting membrane peel, and it went around, but without reaching the actually the foveal area there. So that's not a problem. I just opened. It's like you should treat it as like a tear. So I did the tear in the membrane, and then I switched back the directions. So you see here, I'm switching the directions back towards the foveal area. And since now I have these edges lifted,
We keep going, relieving the
so I keep moving around
360
the
degrees.
foveal area.
We extend the peel furthermore to avoid any scaffolding formation towards the macular area.
So it's easier now to unfold.
We perform some endolaser for peripheral retinal protection. Finally,
It was easier to remove the membrane because I switched directions the other way around. So if I go back here, when I got firstly the membrane and I did the peel, as I said, it did not go to the direction I wanted.
The edges of the membrane. Since the peel is
So then I switched direction the other way around,
hard one, we move it to
as you see here.
clockwise direction and
I
back
changed it
the
from
other way.
clockwise to counterclockwise and vice versa. And then I still grab the edges of the ILM.
Round. We keep going, relieving the attractions and completing the peel 360 degrees.
You always get the ILM back in case you miss it, where the edges are lifted. And so if you have a very good wide angle and also macular view from the ILM, it's easy to get it and just go either clockwise or counterclockwise.
Extend the peel furthermore to avoid any
And
scaffolding
I'm standing the view.
formation towards the
Furthermore,
macular area.
and going back and forth. Now I completed the view,
We perform some endolaser for
enlarging it, doing some of the window laser. Not very many people doing this. I like the window laser just in case for retinal protection.
Thanks
The
a lot.
periphery.
We are
And that was the case from the iTube. I have more there, and it's interesting to see that you might be able to do that without damaging the retina anyways. So what did you guys think? And Rajendra Sarkar is just coming in. Good morning, Rajendra. Sorry to take a little long to put you in, but welcome to our retina course over here. And do you guys want to comment on the surgeries? I want to say good morning to Erica Freitas. She's from Brazil, our very friend. She's a retina specialist. And Nicole, Rodrigo, you want to comment? Let me...
Hello. Good morning, Dr. Hudson.
Hi, Jyot. How are you doing? Good to see you again.
Hello. I'm good. I was there. I just joined a little bit late. I had some issue with the Zoom, but I could see from your first video. So excellent videos.
No problem. Thanks. I was telling you how to deal with the ILM from our some surgeries, and would you have any tip that would share with us, that would like to share with us in terms of the ILM view? How you do it?
Yeah, well, for macular holes, I think it's pretty much as you described, just that I am doing more of inverted flap technique rather than the free flap which you have taken and inserted it back into the hole. So in that, I keep the ILM at the edge of the hole attached uh, at least few clock hours so that I can invert that flap and put it back into the hole. So that basically is useful because the flap will not keep moving around in the fluid. Once you remove a flap and then you leave it from your forceps, then it tends to keep moving around in the fluid and it's very difficult to get it back.
Okay, okay.
So
So how
I just
do you do
use the inverted flap.
ILM? Yeah, inverted flap is a good thing. And what do you do for not letting the ILM escape in case you miss it? What do you do?
Yeah, so what I have been lately doing is I just put a small drop of viscoelastic over it.
Okay, okay, yeah, that's what you said. Yeah,
That just helps to keep it in place.
And this viscoelastic won't fall sideways?
Generally, it will not fall sideways. I mean, again, you have to be very careful with the fluid gas exchange, very like slow and from the nasal side, so that you don't, induce any currents over the area of the macular hole where the ILM is stuffed in. So generally, it holds the ILM there. If you put a drop of viscoelastic over the hole, over the ILM once you have stuffed it inside the hole.
Yeah, very good ideas. And what I did, I have all the videos. What I did, I did the ILM peel as the inverted fashion, as you said, but then
Right.
I did not detach the ILM from the hole itself. I was just doing the round movement, the spinning movement, and removing the ILM. But then I inserted without detaching the ILM from the hole.
Right.
Over sometimes or inside, like stuffing in the hole. So in this case, I didn't miss the ILM flap.
Right. So that I think some people also use the temporal ILM. Like after you complete the peel, you like take a flap of ILM from the temporal area of the hole and then use that free flap, insert it into the hole. That is something which can be done.
Yeah, very good idea. Anybody has
I
any?
just wanted to ask you which forceps are you using, because as you described that the tip seems to be really rounded and non-traumatic. So which forceps do you use?
Well, I will tell. For many years I've been using the Romax forceps. They have different tips. They have different. And then recently I was using the Catalyst forceps as well. Catalyst forceps, a very good one. And they both have the end grips. The end grips, I prefer them more. And because they narrow down the tip at the end to actually grab the ILM. It's a very tiny bending over there, and it's easier to get the ILM. So the tip is not like that, everything touching. So it's open here, and at the end they grab. So there is a distance between the two shafts of the.
Yeah. So that is similar to the Alcon forceps or the Greishaber forceps.
Yes. So I like them both, And those days, my brother-in-law who is from Fine Hub, he's from Pakistan. He lives here in Brazil. He has this manufacturer, and he was doing the making the new forceps. I told him, you should do this and that way, and it's going to work better because we do the surgery and we have this tip this way. And he made some that I was using 2 weeks and a week ago, they are very good, very good. And the problem is that some tips are for single use, and some tips you can use it longer periods. The force, look at that I showed is it's not for single use. So I use it for now over 1 year or 2 years. I don't remember. So I keep it changing. The last one I used was from Catalyst. It's very good. So you gotta choose one that fits well for you, and if it works okay, you keep using that. Of course, you gotta be very careful with grabbing the membranes, and since you know what I tell usually, what I usually tell the fellows, JD, is that you gotta be very sensible. Sensitive, getting the membrane over there and the feeling the membrane, even though it's very thin, and you gotta feel it from the membrane towards the forceps, towards your handle, and towards your hand. If you feel it, everything is going to be okay. If you just go see and do whatever you want to do without feeling it, because what do I say? What do I tell people about feeling and being sensitive on grabbing the membrane? Is where when you grab the membrane, you know whether it's more or less attached. You know whether it's the right place to grab it from, or if you just want to pinch it and move it away from the rest of the retina. Understand what I mean? So you got to feel the membrane. So it's not easy task to do that, but with time, you get that experience.
Yeah, definitely. I think for beginners, you got to be very careful, and as you said that you need to have a very good hand-eye coordination, and the feeling of a membrane is different from the retina, so you need to know that. And sometimes in the beginning you might end up lifting the retina, and then some kind of complications, bleeding, and at times can be disastrous. So you need to be very careful. You should know when you have the ILM picked up, and then only start the peeling. Otherwise, if you just lift and start moving your hand, you might create a tear.
Yeah, you're right.
It takes some time, but definitely your lens, I mean the macular lens and the lenses which you're using are very, very good to have very good depth and a very good resolution. So those are very important when it comes to ILM peeling.
Another thing, JD, is that I like discussing these issues. You see, and I learned this from Dr. Lam. And I learned that in a simple issue, I was doing lasers, and if you don't see you have a hazy media, you don't do the laser. If you see, you go ahead and do it. And that applies for everything, including and especially the ILM, the apparatus membranes, and all things you do in vitreoretinal surgery. So if you see the ILM, you go grab it. If you don't see it, you don't grab it. So what's the point of not staining the ILM? So I like staining. And I remember Steve Charles, years ago, he used to do ILM peel without staining. And then he was, in one of our events, he was telling that he was following some Brazilians that were staining the ILM, either with ICG or brilliant blue. I don't remember which dye he was talking about, but then he saw how necessary and good idea is to stain the ILM peel before going towards it and grabbing it. So still, like he did. I don't know whether he does anymore the ILM peel without staining. I think he stains for almost everything now, I think, for the ILM. So I got to confirm this info with him, but it's important that you see. So if you see it, and some countries cannot have the brilliant blue, for example, Dr. Lam back in Hong Kong, he cannot have the Brilliant Blue because of the issues from the government there, and therefore health issues there, and so they don't allow Brilliant Blue, but they allow Triple Blue.
Trypan blue. They're
Yeah.
using Trypan blue, yeah.
It's not that good, but still it stains the ILM. It stains. I used
Yeah.
I did some surgeries with Triple Blue.
It does, yeah, it does stain, but not as good, and it can stain the posterior capsule also, so then view might become a little bad.
Yeah, that's the problem. If it stains the posterior capsule, then unless the patient is pseudophakic, so but still you don't get that much of a stain as compared to the other way. And so
Right.
interesting issue to discuss. And since we have still 10 minutes, I will display Dr. Oshima's lecture. But if the sound go well, if the sound doesn't go well, because I have this, my computer here doesn't play very good the sound, so I have this Bluetooth, but it's out of batteries. So I've got a very good sound out of here. So now, because it's out of battery, maybe won't display a very good sound as well. So if it does not, you could continue next week, no problem. Because these things are so interesting that we discuss with time. And I want to thank Dr. Anshuman Singh to participate. And I think it's an honor for us to have you here, Dr. Anshuman Singh. I guess
I think it's Dr. Anshuman Sinha.
Yeah. Mm-hmm. Thank you very much for participating. It's an honor for us. Anytime, if you want to comment, this is a good thing for us that we discuss the cases, and that's why we are here mostly. So let me try to share Dr. Oshima's video over here. Let me see if you tell me whether the sound plays okay, or Jyot, let me share the screen again.
Sure.
Okay. Can you see the screen?
Yeah, it is visible.
Hi, Francine.
So this was the Retinawesome meeting. So I'll go straight to the point. This was the Retinawesome meeting number 5. And just that you remember, we have the Retinawesome meeting number 7. The subject will be 007 challenging retinal cases next December 5th, Saturday.
Right.
And we have here the speakers from Retinawesome 5. And we are starting now with Dr. Oshima.
Zoom now. I think the idea will be to find out the least way to treat an eye. And I think this particular case is an example. All of us are agreeing to the.
This is Natarajan. Can you hear well his voice?
By doing an example.
It is audible, but it's not clear.
Okay, let me try putting this mic a little closer.
In the last 4 retinawesomes, we saw everything which we are doing through the past pen, and I think that's the reason I was thinking I should do something as a keynote speaker. And I'm happy we brought out a point to the young people that everything old is not bad, and everything old is also not great. And I think you should take up which is good for the patient, and I think that's what I think is a good last point by Wei-Ching Lam. Is great that we as an experienced teacher want to tell the students, please pick up the right thing to do for the right patient. And whatever you hear, don't apply directly without knowing what it is. And I think you should have some experience. And when in doubt, please ask. Just don't do with doubt.
Thank you very much for all the comments. We should go to the next case. Thank you, Dr. Natasha. Dr. Oshima, do you want to share your screen to see your video, please?
All right. So just one comment about the last case and Ati talked about. Of course, I also very agree with that. Doctor talk about the laser mainly for the stabilized aneurysm. But sometimes, you encounter very big hemangioma. It's not easy to use laser only. So in such case, I still prefer use the cryo. Right, combined with intravitreal injection of steroid, because stabilize the inflammation most of the case. Otherwise, the big one, I don't think laser is a workout for such a case. All right, let me give a talk about this maybe the traditional strategy for the option for the subretinal hemorrhage treatment. I just show you some option, and I would like to discuss with the panelists about which was the best way you like to do for such a severe case. So, can I see my slides?
Yeah, perfect. Okay. Thank you.
So, the natural cause for the subretinal hemorrhage due to the AMD is very severe, so we need to use some surgical or the pharmacological strategy to treat this case. So recently, most doctors recommended use the anti-VEGF injection, but just like this case, of course, this case is very, the activate CMV with the wide subretinal hemorrhage. How would you like to treat this case? So some cases, doctors still talk about simply use the anti-VEGF. So anti-VEGF can stabilize the neovascularization activity, but it's not easy to disrupt the subretinal hemorrhage so immediately. So anyway, at the end of the day, you can see, of course, you can select the neovascularization, but when you use the autofluorescent, you can see very wide layer at the post-pro, the degenerative RPE. So even though you can stabilize the activity and resolve some hemorrhage, finally you can see the very big scotoma and the fixation point shift to the near the arcade. So that's the reason why you can only get very low visual recovery. So the much more less invasive surgical approach is simply use the gas for the displacement of the subretinal hemorrhage. This is a typical case with the PD and the subretinal hemorrhage and the sub-RP hemorrhage here. So simply inject of the C3A with the expansive gas. You can utilize the pneumatic displacement. You can displace the subretinal hemorrhage. So in this case, it works very nicely. So you can displace the subretinal hemorrhage to the inferior side and only leave the PED here, so we can get better visual recovery in the case. But not all, every case can be rescued by such case, especially if it's not a fresh case. It's not sometimes doesn't work. For this example, this case, if you use ingest, here to show you our standard technique for the pneumatic aspiration, pneumatic displacement subretinal hemorrhage. I simply prefer use once this is syringe is first aspirate the aqueous humor 0.3, inject 100% C3 gas 0.5 millimeter into the intravitreal cavity, and make the face down position for 5 minutes. Then you can accumulate the aqueous humor, refill the volume to the antechamber, so we can re-aspirate the aqueous humor 0.2 millimeter more. So totally, you can balance the total volume with aspiration and injected volume. So in this case, you can see we can work very nicely and you can get a very excellent visual recovery. There are actually here, not every case can rescue by this simple injection. For example, this case, we are a little old, subretinal hemorrhage. Even inject gas, it doesn't work. Another case here, we can encounter the visual hemorrhage, a much more severe case, which more dense hemorrhage. And otherwise, it's like recurrence will occur in such a case. So in such a case, I still prefer use the surgical approach, vitrectomy combined with subretinal injection, TPA, and sometimes also combined with the anti-VEGF drops, and make the fluid exchange of the volume of the 50% intravitreally, and you just like the accelerate the accelerate the displacement of the C3 gas. So here there's a schema scheme we how to use it. And this is the original technique already reported in several previous literature. And we use a very small gauge needle to inject the fluid and expanded the artificial detachment. And with combined with TPA or end with anti-VEGF, and with wait about 30 minutes, you can liquefy the subarachnoid hemorrhage, and you can locking technique and shaking, and make it much easier to make sure the BSS with subarachnoid clot. And finally, you inject only 50% of the vitreous cavity volume to gas, and rate, and can make the face down position a couple of days, can displace the subarachnoid hemorrhage. So in the case with hemorrhage only localized around the arcade area, this sometimes the paper talk about this is massive, but we don't see it massive. It's a moderate subarachnoid hemorrhage. We prefer use the technique to accelerate the displacement of subarachnoid hemorrhage. Here I show you the 27 gauge surgical technique. This is a little bit old video. We use the dark cannula. And this is the 29 gauge twin light changer from the Astron right now. It's commercially available. And then use the wide angle system. We can see this is a little bit of old subarachnoid hemorrhage, so it's not easy. You only use the gas only, can displace the subarachnoid hemorrhage. So I prefer use the subarachnoid injection. So initially I do the iron peeling, and then I inject the subarachnoid BSS with TPA. And during the concentration, maybe around 50 microgram to 100 microgram per injection. Otherwise, we encounter some subretinal toxicity of TPA. So no more than 100 micrograms better. So in this case, a little bit old one, so I prefer to create the artificial detachment widely, and then wait for about 30 minutes, and then use the locking technique to shaking to create the attachment much wider and make sure the BSS with the subarachnoid clot. And then try to use the gas, not fulfill the gas in the vitreous cavity, only about 50% or 6%, because leave the other place to can displace the subarachnoid hemorrhage to the inferior side. And simply move all the trocar cannula and to enter surgery. So, as you know, Dr. Tamara also deployed much more fancy technique, use the subarachnoid air bubble injection. But the one concern about it, my personal impression about it is that if you inject the bubble so quickly, you may separate the adhesion between the retina and the RP. So sometimes, of course, you can display the subarachnoid hemorrhage or subarachnoid clot to other place, but sometimes you encounter the much higher damage to the photoreceptor. So personal opinion, I prefer still use the BSS to gently separate the retina from the clot and separate it from the RP to avoid much severe damage to the photoreceptor. And show this case we can get very good favorable results. How about the much more challenging case? This is the bolus attachment with the wider subarachnoid hemorrhage. Sometimes this case in Asian people, we often encounter this situation because most of the people that AMD is due to the PCV. Once the pupil rupture, they may encounter much more severe, just like this show here, the total attachment with subarachnoid hemorrhage. And in such a case, we already published the previous paper, the video, about how to treat that one. So most of the surgeons, like the European surgeon, prefer use the large or the wide retinectomy or retinotomy to invert the retina and directly aspirate the subarachnoid clot. But most of the surgeons show such a technique, a very skillful surgeon, so he can do it very well and use the silicone oil to terminate and stabilize the subarachnoid CNV activity and attach the retina very well. But wider retinectomy and counting PV are much easier, especially the case, the AMD case, sometimes that RP is already very severely deteriorated. It's not easy to attach to the retina. So for us, we innovated a very small, much what's it called, less invasive technique, because in such a case, it's not we recommend not to make the retinal breaks at the posterior side, because such a case, the RP around the posterior side already degenerated. So once create some intergeral hole to aspirate subretinal hemorrhage, after that it's not easy to attach retina, close the posterior bricks, because the RPs are degenerated. It's not easy to attach retina. Once you encounter, you make the posterior hole, you may encounter PBR much easier. So even such a case, peripheral RP is most healthy. So we prefer, in such a case, we try to perform the intravitreal injection TPA 1 day, 1 or 2 days before the surgery, skip from surgery. And of course, during the surgery, we also prefer to inject the TPA just like the last case showed. But in this case, we inject much more widely to make a much wider lesion attachment. Because we have the experience, we use the translocation, we don't care about how wide or how steep bolus detachment we can create. And the point is to create a peripheral retinectomy at the upper side. You can do the temporal upper side or nasal upper side. You can make 2 or 3 bricks there, because we can try to, in the case, we try to use the peripheral carbon to displace the subretinal hemorrhage from the posterior to the periphery, and makes the evacuation of subretinal hemorrhage from the peripheral retinal bricks. And of course, in such a case, you cannot remove the subretinal hemorrhage 100% during the surgery. You should encounter some subretinal hemorrhage still remain underneath the retina, but don't care about it, because in such a case, we finally repeated this technique, injected the peripheral carbon, aspirate the hemorrhage, and then shaking, and then inject more and aspirate. Finally, you can still reduce the volume underneath the underneath the retina, but you cannot remove all the subhemorrhage, of course. So finally, here we don't like to use the silicone oil. We simply use the cryo to make the retinopexy and inject the long-acting gas in it. And then we make the face down position after surgery, and then we can use just like the pneumatic technique to displace the subretinal hemorrhage from the peripheral retinal bricks we made. Because we use the cryo here, it's not laser. So even the subretinal hemorrhage passing through the retinal bricks, the long-acting adhesion by the cryo can finally seal the retinal bricks in this technique. So in just a technique only used to make the small bricks at the peripheral area. That means much easier to attach the retina and count much less the case of the PBR. We already used this technique for over 20 to 25 cases. We have never encountered any PBR in such case. The one drawback is we need to remove the lens, because we accelerate the subretinal remove the crystal lens. If the pseudophakic eye is okay, and because even the pseudophakic eye that displays subretinal hemorrhage into the antechamber, you can aspirate from the antechamber by the prosthesis a couple of days after surgery. So here showed how to treat the case. This is a case with wide bolus detachment with subretinal hemorrhage. Here is a 27 gauge. And you can see here, and the very dark clot. And initially we perform the peripheral shaving, of course we create the PVD, and then use the test 27 gauge and 41 gauge subretinal injection needle. We use the active injection to inject the TPA with VSS in subretinal space. And you can see the increasing the volume of subretinal space here, show here, and waiting about 20 to 30 minutes, you can liquefy the clot. Just like show here, the color change to the much fresher red. And then we use the shaking technique to make much wider area of detachment. And here make the clear to break the bricks from the peripheral area, and then gently inject the peripheral carbon. You can see very dense and the sand-like, the high viscous subretinal hemorrhage can passing through the peripheral area. So we use the technique. You need to repeat it several times, but finally you can get to remove the around maybe about 70 or 80% of subretinal hemorrhage. Only remain a little bit, still accumulate that positive, but don't care about it. After ILM surgery, make the pneumatic displacement can demonstrate that the residual subretinal hemorrhages passing through the peripheral breaks after the face down position. And the DM surgery can see easy to close out the wound. And here show this case. Finally get, this also show here, we can get the complete subretinal hemorrhage removal without encountering any severe complication. Folks, in such a case, it's the most RP already damaged, so the visual defect already maybe occurred and the visual recovery may be very severe, but it can prevent the blind, even such a severe case. So my personal choice of the surgical option for the subretinal hemorrhage treating is, if it's not massive hemorrhage, if the fresh case, we use the pneumatic displacement. If the dark clot case, we can use PVD combined with the pneumatic displacement. If a very old case, of course, it's very challenging. If it's the last line, I still try to use surgical approach. But if it fails, it's visual acuity, it's worked very well. I just simply use the VGF and the VGF to stabilize the neovascular activity. If it's very bolus subretinal hemorrhage case, severe case, if the fresh one, I try to use the PV vitrectomy with the TPA injection subretinally. And if it's a dark clot also, just like this case, I showed you the surgical approach. And with the old case, the old one, I just only do the observation, because if it's a much more severe solid clot, it's not easy to liquefy. It doesn't work even with the subtechnique. Otherwise, another choice is a wide retinectomy to remove all the subretinal clot. But that's maybe increasing that complete high incidence to completion about the PVR. All right, thank you for your attention.
Great, Yusuke. I think wonderful surgical techniques. And the only comment is that the last case where you did you injected a TPA, waited for 30 minutes for blood to liquefy. Once I operated Mark Humayun Zohan, came from Pakistan, and then it was about 25 years back. So bullous subretinal, at that time I was not confident of doing the TPA and then doing it. So he told me, why not you do a vitrectomy? 25 gauge, that time 27 was not there. It was running 2005. So we did a 25 gauge vitrectomy, inject TPA, and put a C3FA and put her on head-up position. All the subretinal hemorrhage came down from the macula at least, and then the inferior hemorrhage went away. So I think the patient got good vision, and then later did a PDT. So maybe that one option is there for a massive subretinal hemorrhage for a surgeon who's not very confident. But a surgeon like me, we can do this TPA and clear the entire thing and have a good visual results.
Yeah.
Thank you very much.
Yeah, other technique they can use the external drainage of the subhemorrhage, but just we'll talk about the subject. External drainage cannot remove the 100% of the.
So interesting is a lecture, very complete lecture from Dr. Oshima on using the TPA for massive subretinal hemorrhage. This was really cool, whether
Yeah.
hemorrhage is fresh, new, or old, and combined with partial vitrectomy. JDP, it was interesting to see how he removes from a small retinotomy, the hemorrhage, and keeps injecting the TPA and waits for half an hour and to get the hemorrhage liquefied. And so he can remove the hemorrhage from the subretinal space, and he keeps repeating that during the surgery. So the surgery could last hours, maybe 2 hours or more, and to remove it and put it the TPA back and remove it again. And he mentioned the shaking technique. He was just shaking with the tip of the forceps on the, I guess the forceps, or could be the cutter without damaging the retina, just to move the retina backwards and here.
Yeah, I think the most difficult aspect here is to create the artificial retinal detachment with the 41 gauge cannula, the needle, 41 gauge needle. It should be available, you should have one, and then creating that artificial retinal detachment at the posterior pole, probably that is something which has a learning curve.
Yeah, it is to create the artificial retinal detachment and then not be able to attach it. It's a bad issue, but as he said, many people do that very good, very well with silicone oil including. And the good thing is to peel the ILM. He was peeling the ILM as well for some cases, and he was talking about PVR. We should avoid doing too much of the retinectomy unless it's necessary. As he said, before he did the retinectomy, he attempted to do other things as well, such as small retinotomies, drainage injections, and combined with postprandial vitrectomy and ILM staining and peeling. And then we should avoid large retinectomies for removing the massive hemorrhage because of the PVR issues.
Right.
Explained, very well explained.
And, but I didn't. How do we do ILM peeling in such a case where there is already subretinal hemorrhage? You peel first and then you do the remaining things. But then, does it stain? I mean, would you be able to see the ILM with the blood underneath?
Yeah. That's it. That's what I would do. Some drainage first. Otherwise, I wouldn't be able to see the ILM. Maybe I don't know, because I don't usually do ILM peel for these cases, and even though it's a massive, I go in a moderate way. I prefer to do injection and then injection plus gas to displace the hemorrhage, and then if nothing happens, if it's taking such a long time to resolve, then I would go for a vitrectomy with a retinotomy and go on with other repairs. But it's a good idea that if you could do the ILM peel beforehand, it's better. But if you cannot see because the hemorrhage is down below, maybe it's better to remove it. But good idea.
Probably it can be, after removing the blood, then he was injecting the perfluorocarbon. Maybe just before that, do the staining with brilliant blue and then do the peeling under the ILM peeling under the PFCL.
Yes, and also the perfluorocarbon helps to displace the hemorrhage. But if it escapes out towards the vitreous cavity, then you need an extra time to remove and clear up the vitreous from the vitreous cavity. But still, the good thing I like to do the ILM peel with using the perfluorocarbon is that I do vitrectomy and then I do fluid exchange. After fluid exchange, I use brilliant blue to stain the ILM very well, and then after seeing the ILM, and then under perfluorocarbon, then could be easier to get the ILM because the perfluorocarbon is putting the retina down, so wouldn't move.
Yeah, I agree.
These discussions today were very rich, and I learned a lot from seeing this video from Dr. Oshima again. And I just did a case yesterday, 2 weeks ago, actually, a TPA injection, and then I did anti-angiogenic yesterday as well for the same patient, and the hemorrhage is clearing up, and I'll give you feedback in the following day. And thank you very much for all your participation, and I know the lectures help us discuss, and also these lectures are displayed in YouTube for the residents and fellows for further knowledge and learning, and the good thing is to discuss. And do you want to say anything, Jaydeep, for us closing the meeting?
No, well, it was an excellent discussion today and very interesting cases, and probably some things we can pick up from every time we discuss and implement in our practice. It's very interesting to have these discussions because Otherwise, you are always following your things, and you don't really you do attend or you see things, but then unless you discuss, you don't tend to implement those things in your practice.
Yeah,
So
yeah.
this is really useful.
Yeah, good thing is to discuss. That's why we participate into congresses,
Yes.
and we are more online than everything. And I'm learning from your experience, Natarajan's experience, Oshima's, and everywhere. So the good thing is that the next time I'm going to try this and that and do the other way around. And I will plan my surgery for massive hemorrhage subretinal by doing vitrectomy injections. And this is good for, discussions is good for us to decide whether to do this and that, and if we are going in the right directions.
Yes, yes, definitely.
Thank you very much.
Definitely.
Thank you.
Thank you, everyone.
Thank you, Ashwara. Have a good day, you too, and everybody. And hope to see you next week.
Definitely, sir. Thank you.
Yes.
Bye.
Bye. Bye. Have a nice day.
You too, guys. Bye-bye.
Bye.